Hello, here is assignment 4, Airway Management. So the case that I decided to talk about is about a 62-year-old male who had fallen at home after a night out drinking at the pub. He was found collapsed on the floor and they put him in a C-spine collar. He came into the OR, I think it was a day or two later, for a C3 to C6 laminectomy. So when we did our airway assessment, he was in the C-spine collar. So he had limited neck mobility. He also had limited mouth opening and what looked to be a Mallampati 4. He had a large tongue, he had some facial hair, and a full set of teeth. His thyromental distance did look to be adequate with 3 finger widths. So with that assessment, he looked like he would be a difficult intubation. We also assessed him for a difficult bag mask using the MOANS acronym. So the Mallampati 4 and mask seal difficulty with the facial hair. He did have a large tongue, so might have issues with obstruction. His age wasn't really a concern. He did have a full set of teeth, so that wasn't a concern. And then, of course, stiff neck with the C-spine collar. So then that also led us to a difficult bag mask. So with the anesthesiologist that I was working with that day, we decided that we would go for an awake intubation, and we were going to use a lighted stylet. Our plan B was to use a gyroscope. And then we also had the difficult airway cart pulled just outside the operating room theater. So then we would also set up all appropriate monitoring, ECG, blood pressure, and saturations. We would need some lidocaine spray. We're going to use a number 8 tube with smaller size for backup. We would need a good IV, and we also have emergency drugs on standby. So the first step for this intubation was going to make sure that the patient was nice and pre-oxygenated. So with 100% O2, we're also going to have nasal prongs on during the intubation. We're going to topicalize the airway with local anesthetic. We're using 2% lidocaine spray, and make sure that the airway is nice and frozen. This patient was a little bit anxious, so we drew up some remifentanil. I believe he gave him 30 micrograms initially and just titrated that to avoid any respiratory depression. So then at that point, we dimmed the lights in the operating room theater so we could see the light, inserted the lighted stylet, and just adjusted it until we could see it shining through the cricoid membrane. We knew that we were in the right position in between the cords. We slid the number 8 tube down through the cords. It is a blind technique. And then we removed the stylet. We confirmed our placement with bilateral chest rise using auscultation. We could see misting in the tube, and then we also got end-tidal CO2 on our monitoring. So then, yeah, we had a successful difficult airway intubation and didn't have to fall back on any of our plan Bs or emergencies.